I would like to welcome you all. This presentation is about the intravitreal injection procedure. The Royal College of Ophthalmologists guidance for intravitreal injection is one of the most solid guidelines regarding this intervention. Also, different techniques and tools used for injection are going to be shown. Some of them I tried myself. Finally, we will highlight the intravitreal injection complications. Our aim is to deliver sterile drug into the eye and maintain its sterility. The most important tip is to avoid contamination of the advancing needle by avoiding touching the lashes or the lid margin before entering into the sclera. In some parts of the world, intravitreal injections are performed by paramedics as nurse practitioners. This is done by well-trained and qualified personnel. It really alleviates part of the injection burden over the ophthalmologist. Intravitreal injection way of treatment entails crucial steps before entering the injection room. First, clear diagnosis and injection protocol are clearly explained to the patient. Also, the possibility of frequent injections, recurrences after improvement, and expected prognosis have to be discussed neatly and ensure that the patient is well informed. Initial visual acuity and at each visit with detailed documentation is the key for optimum outcome. Also, at the initial visit, it is better to describe the procedure and to simplify the idea of putting a needle into the eye. It really helps at the time of injection. The first step is the periocular sterilization by adding 10% betadine and to wash the conjunctival sac using 5% betadine for 3 minutes as recommended by all guidelines. So how do we inject? It is advised to confirm that the intraocular pressure is not elevated before injection and to ensure no ocular inflammation or infection at the day of injection. After betadine wiping, a drape is applied then the eyes are opened by a lid spiculum and 5% betadine are instilled into the conjunctival sac. The patient is asked to look in the opposite direction to the quadrant that is to be injected, and a caliper is used to measure 3.5 mm for pseudophakic and aphakic and 4 mm for phakic patients as a site for entrance into the sclera. It is advised to displace the conjunctiva before injecting so that entry at the conjunctiva is different from scleral entry, thus no direct route between vitreous and ocular surface. Also, different scleral sites should be used for subsequent injections to avoid scleral thinning and future necrosis. The needle should be inserted perpendicular aiming towards the posterior pole or the optic disc. And after injection, it is mandatory to assess that the patient is counting fingers to exclude central retinal artery occlusion that rarely happens. I encountered this situation once and with ocular massaging only the patient regained his vision within 2 minutes. For bilateral injections ever to be done, the whole procedure with complete new set of instruments and different patches of the drug to be used. Despite that central retinal artery occlusion is very rare to happen after intravitreal injection, knowing how to act if you encountered such a stressful incident is a sight saving. If the patient reports no PL, start ocular massaging for 1 minute, then reassess the patient. If still no improvement, immediate paracentesis reperfuse the central retinal artery again and vision is regained as reported in most of the situations. After injecting the patient is discharged and informed about 3 entities. The first one is the post-injection eye drops, the second one is the signs of endophthalmitis, and the third one is the hotline or the contact number to call in case of emergencies. The patient should be informed about seeing floating spots after injection. It may fear the patient if he doesn't have a preset idea about this sign. Commonly, intravitreal injection is done under topical anesthesia as it is done sometimes as an outpatient procedure in clinic. Several injection angulation were compared to measure which technique has the least reflux of the drug. It was found that going into a biplanar or a triplanar through a scleral tunnel formation have a lower vitreous reflux than direct injection. However, going straight as in figure A has less complication and much easier for the patient and for the doctor. So, does intravitreal injection cause elevation of the intraocular pressure? Actually, that was an issue with large volume injections as in old schools, where they were injecting the double effective dose of bevacizumab in 0.1 milli instead of the 0.05 milli we use nowadays. Fortunately, nowadays all intravitreal injected drugs, the effective dose is in 0.05 milliliter, where intraocular pressure spikes are very rare, and paracentesis is not a step of intravitreal injection anymore. So, do we need to prescribe post-injection antibiotics? It is traditionally prescribed and to safeguard your patient from the risk of endophthalmitis. However, clinical trials negated the use of post-injection antibiotics, and it showed that the risk of endophthalmitis without prescribing antibiotics was much lower than adding a post-injection antibiotic. Many devices were invented to lower the risk of endophthalmitis post-injections and to make the procedure much easier. Guarded injection device is a needle with a coating rubber sleeve that retract and allow the hidden needle only to enter the sclera, thus to avoid needle contamination before entering the eye and lower the incidence of any infection or endophthalmitis. Another device is the InVitria injection assistant. I used it for hundreds of patients. It's really easy and time saving. especially for outpatient injections. It is a plastic cup applied over the limbus, so it fixes the globe and the needle is applied through a side tube. This side tube maintains the scleral entry side to be a 3.5 mm from the limbus. It is widely used in UK because injections are commonly done by nurse practitioners, thus ensuring less complications and standardizing the injection technique. Despite that intravitreal injection is a simple, effective procedure, it carries some risks. Some of them are nightmares, and it is highly recommended that we discuss the issue of complications at the initial visit so patients are informed and consented properly. Here is a list of the possible complications, with the most dreadful one, the endophthalmitis, with a reported rate of around 1 in 1,000 of patients. It has to be differentiated from the post-injection inflammation or reaction because they are treated in different ways. One of the most important differentiating signs is the pain associated with the endophthalmitis and not with the inflammation or reaction. And finally, thank you for your attention.